Very good afternoon to everyone. And it's a impressive meeting, impressive talk, especially the session on mental health. Really impressed with the initiatives that the FPI is taking. And going forward, a talk on palpitation, what can be a better talk after the talk on mental health? There is so much of close correlation. Lot of patients also would, those with mental health might have palpitation. Those who have palpitation ultimately suffer from mental illness also because of the chronicity of problem. So I think, can I have my slides, please? It's there. Fine. So I thank Dr. Pragnesh for inviting me for this talk, which is ultimately going to back to our MBBS days probably. We might have been taught about palpitation way back in second year, third year of clinical postings. So with kind permission of chairpersons, we'll go ahead with the talk. So we'll try to stick to basics and put in diagnostic intricacies in the talk. So as we know, subjective perception of own heart beating is described as palpitation, and we know that altered chronotropy or altered inotropy both may cause it. It is commonly equated to fast heart beating, but we must understand that it may not be that fast always. One can have slow palpitations also or not very fast heart beating as well. And therefore, whenever we approach a patient with a history, we should look into it. How fast was the palpitation? So commonly, the heart rate beyond normal limits, but when it is proportional to physiological needs, palpitation may be there. Common examples are exercise and mental stress. There can be heart rate which is disproportionate to physiological needs, like in presence of supraventricular tachycardia or atrial fibrillation, sympathomimetic drugs, commonly cough syrups, which can lead to tachycardia and palpitation. Then there can be irregular heartbeats because of ectopics happening, which can be ventricular, atrial, or junctional beats leading to palpitation. And there could be conditions with increased cardiac output, mainly in the conditions like aortic regurgitation, anemia, thyrotoxicosis, complete heart block. All those things can also present with palpitation. These are common associated overlapping symptoms many patients with palpitation would come with. That can be syncope, pre-syncope, fatigue, and dyspnea. So we need to assess a patient in totality and not just focus on the history of palpitation. Let's deep dive into the topic with some case examples, which are real life scenarios. So this is one class 10 student who was attending a class at a coaching center. So class 10, everyone can relate to. They are mentally stressed out. Teacher yells at the student as he was sleepy. Maybe he has not slept well previous night. He was sleepy in the class and the teacher yells at him to wake him up probably. Others note that he shivered and passed out for a while. He was sent home with a note that he has attention issues. And because he passed out, he was brought to a checkup. On interrogation, he said that he did have some palpitation before passing out, and that history is important. Not just related to the history that he just passed out because of lack of sleep. Clinical examination was unremarkable. Echo was structurally normal, and this was the ECG. I think Dr. Pragnesh is there, and many of you who have a ECG machine with you will be able to see that this ECG practically looks to be normal, right? It looks to be fine. There is some variation in RR intervals, which is physiological at this age, because these patients do have a good amount of vagal tone also at this age. So it could be sinus arrhythmia, which is otherwise normal. So this is entirely normal looking ECG when we have a first glance of it. But when we look at close, what is important is someone who has passed out, we cannot really allow him to go like this. We need to look closer. And what we see here, focus on T waves. T waves are showing bifid nature. that bifid nature of T wave alerts us that this is not normal. A bifid nature says that this patient is at high risk of developing ventricular arrhythmias, and his repolarization, cardiac repolarization, is at fault. A normal T wave is rounded. It's never peaked. It is rounded in contour, single peak, never bifid. So a broad bifid P wave raised the suspicion that that event was malignant. And what is that malignancy? This. It is torsade de pointis. It's called polymorphic ventricular tachycardia. These patients are prone to develop ventricular tachycardia and sudden cardiac death. This was typically a type 2 long QT syndrome in which the QT intervals may be labile. They may be exercise related. They may appear after exercise. They may not be evident on first surface ECG. So long QT always may not be evident on first ECG. It may be labile. And therefore, it is important that all of suspected patients need to have a Holter monitoring. They should be undergoing stress testing if and when required. And important is that a family history also should be asked about whether they have any family history of sudden cardiac death, right? So important here in this patient was that this particular type of long QT syndrome is precipitating arrhythmias because of auditory stimuli or loud noise or thunder or even sudden waking up, right? So these kind of things also bring about triggered activity in patients who have vulnerable QT interval prolongation leading to palpitation and syncope, right? Most these patients are well on beta blockers, mostly propranolols, and resistant cases will need cervical sympathectomy and AICD implantation. A second 30-year-old male recently changed his job, again temperamental issues and marital discord. Came with palpitation and fatigue when he was pulling his bike at roadside. And the ECG showed this. I mean, now everyone would be able to answer this. A deeply inverted T wave, evidence of LV hypertrophy. Yes, apical hypertrophy, typical, right? When you do echo, it is showing hypertrophic cardiomyopathy, right? So exertional palpitation in hypertrophic cardiomyopathy is largely because of tachycardia leading to fall in cardiac output. But some patients can have exercise-induced arrhythmias also, which can be fatal. Cardiac MR is recommendable in all these patients to detect myocardial fibrosis, and beta blockers, and again, implantable cardiovascular defibrillator are the treatment of choice to prevent sudden cardiac death. Again, a 22-year-old female, pregnant, and has severe mitral stenosis, pulmonary hypertension. So palpitation is very common in all these patients, right? But this patient had a spontaneous palpitation at rest, not only exertional. She had palpitation at rest, right? So commonly we would feel that it could be atrial fibrillation, right? But what the surface ECG showed was, I'm sorry about the resolution, but yes, it shows a WBW syndrome, right? It shows delta wave, pre-excitation, broadening of QRS, telling that it is not only rheumatic heart disease which is making her symptomatic, but she has associated SVT happening, supraventricular tachycardia because of WBW syndrome happening. A 60 years COPD becomes worse after nebulization. What does it show? Again, it shows tachycardia, which is showing right bundle branch morphology, and there is equal number of P waves with equal number of QRS and a typical right bundle branch morphology looking like atrial tachycardia. So at times, sympathomimetic drugs as a part of nebulizer therapy can precipitate tachyarrhythmias, and COPD having hypoxia and increasing pulmonary pressures also can give rise to arrhythmia, and you can have presentation during COPD exacerbation, arrhythmia as a pathology which can make their condition worse. Largely nebulizers are not majority problems, but salbutamol group of drugs can cause tachycardias, right? 52-year male with exertional palpitation, mind well. So resting ECG was normal, no diabetes, hypertension, normal resting ECG, resting echo normal. So we made him subjected to treadmill. That since everything is normal and your symptoms are only exertional, better you go ahead and do a treadmill. What do we find on treadmill? So treadmill shows, what do you see? Treadmill shows, again, every QRS has a preceding P wave, but the QRS duration, the width of QRS changes. At times it is narrow, at times it is broad, at times it is intermediate. If you look at the first panel, you can see that there is P wave followed by QRS, but all QRS complexes are having different width. Why is it so? Because this patient has associated, again, WBW syndrome. So part of conduction is happening through node, part of conduction is happening through accessory pathway. So ventricle is activated by two different inputs, node as well as pathway. If it is dominantly through node, QRS is narrow. If it is partial through both things, QRS becomes broad. If it is only through pathway, it is absolutely broad. So because of increasing sympathetic tone, conduction across pathway as well as node increases, and therefore this gives you different degrees of fusion, leading to narrowing and broadening of QRS. So picked up on treadmill, this is WPW syndrome. Again, picked up on treadmill, not on surface ECG. So it is important to evaluate based on history what the patient has, and that can give you a clue to diagnosis, right? And lastly, a patient on pacemaker complaining palpitation. Like pacemakers are put for what? Bradycardia indication, right? That patient does not have his own rhythm. He has problem with AV block, or patient has a sinus node disease, so patient is unable to generate their own cardiac activity. So what if that patient complains of palpitation, right? And if we see here, rate is pretty high. And this patient did receive every antiarrhythmic drug before coming to us. Like he had amiodarone given, beta blocker given, digoxin given. It does not change the clinical profile, right? So this was nothing else but a pacemaker mediated tachycardia. Like, so pacemaker, we have to program the rate, and we have to program refractory period of the particular lead also, atrial lead and ventricular lead. So if refractoriness is short, you can have pacemaker mediated tachycardias happening, and it is not amenable to medication therapy. You have to prolong the atrial refractory period in the atrial channel. That can improve overall. It can terminate the tachycardia. So I think I'll not go into the details of everything because the time won't permit, but I would end the talk with this, that we have a broad spectrum of differential diagnosis with palpitation. Important is history. ECG, in carefully selected cases, even treadmill, echo, and extended Holter. Cardiac MR and FDG PET are important evaluations for ventricular arrhythmic disorders who present with history of palpitation. And lastly, genetic testing is important in those with suspected disorders of inherited channelopathies. Thank you for a patient hearing.
Thank you.